I think first and foremost, I think the general feeling is that waiting until patients get this treatment in the third line setting is probably a little bit too late. So certainly there are at this point actually 10 other phase 3 studies that are either ongoing or recently completed that are now evaluating it also in the first and second line setting. And the hope is that by incorporating it earlier on in treatment, potentially more patients will derive benefit. But at the same time, I think the other two key paths to trying to improve the degree of response and the number of patients who respond is really better biomarker selection. So up to this point in the entire field of immune checkpoint inhibition, the main biomarker, of course, has been PD-L1 expression on the tumor cells, but we know it's not perfect. When we use PD-L1 as a biomarker, PD-L1 positive tumors respond about 25% of the time. PD-L1 negative tumors respond 10% of the time. So in other words, even though tumors that are positive are more likely to respond, it's certainly not 100%. And correspondingly, tumors that are negative can still have response and benefit. So I think in addition to PD-L1, other biomarkers will have to be evaluated, including potentially gene signatures to identify hot versus cold tumors, potentially some assessment of tumor mutation burden, and then potentially some attempt to correlate response with the molecular subtypes from the cancer genome analysis. But at the same time, in addition to trying to better identify patients who will and will not respond, the next generation of studies that are already beginning to take off are really looking at combination strategies. So in other words, combining, for example, nivolumab with ipilimumab. There's a phase 3 study that's currently ongoing, looking at that in the first line setting versus chemotherapy. But at the same time, there are many other immune checkpoint agonists and antagonists that are being looked at. We're beginning to combine these drugs more and more with chemotherapy, with vaccine strategies, with other immune adjuvants. And I think one really interesting area is to begin to look at these medications in combination with radiation. And the idea is to try to increase what's called the abscopal effect, meaning that we give radiation or ablation or some local treatment, we kill the tumor cells, their intracellular antigens are released into the bloodstream, and if the immune system is activated, it's able to recognize that. So I think, with a combination of all of these strategies, I really think this is the first step in what is a paradigm shift. But I think the hope is that in the next 5 years, we will improve the effectiveness of these treatments.